Evening to many of you, and good afternoon to the others that are on the other side of the coast. I am Darcy Zableski. I am a nurse practitioner and education consultant. And on behalf of Blood Cancer United, formerly the Leukemia and Lymphoma Society, NNMDP, welcome to this Project ECHO Session 2. Treating Acute Leukemias, Blood Cancer United, NMDP Project ECHO series. In today's sessions, we will discuss evolving treatment in cell therapy and transplant. This is Blood Cancer United and NMDP's second Project ECHO session, and we are so excited to be with you today. If you have participated in a Project ECHO session before, please share an emoji reaction now, and hopefully many of you watched the first one. So I'm hoping to see a lot of emojis. We got some. Good. Here we are. Oh, we got a bunch of hearts. That's fantastic. It's good to see all of the people returning and new participants as well. So with that being said, I am going to have the speakers introduce themselves, and then we will move on to a little bit more housekeeping.
Good evening. I'm Shernan Holton. I'm the Chief of Blood and Marrow Transplant at Roswell Park in sunny Buffalo, New York.
Good evening, everybody. I'm Allison Lauren. I am the Chief of Blood and Marrow Transplant at the University of Pennsylvania. I will tag Dr. Mims.
I am Alice Mims. I'm one of the section heads at Ohio State University for Acute Leukemias and Myeloid Malignancies. And I'll tag Dr. Alsfeld.
Hey, everybody. I'm Clark Alsfeld at Ochsner MD Anderson in New Orleans, Louisiana, and I focus on leukemias and transplant.
All right. And we just need our slides shared. There we go. And we can move to the next slide, Sam. So as you've just met the faculty, and on the next slide, the learning objectives are listed on this slide. We will record this session and post it on the Project ECHO site in the next few weeks. If you do not want your video to be part of the recording, feel free to keep your camera off by using the black menu bar on the bottom of your screen and turn it off. But otherwise, we would love camera on to have this be a community feeling. Remember, please don't share personal identifiable health information about any patients during our discussion today. We do ask to make sure to have your first name, last name, and organization included in your name so we know who is participating. And again, this is also all part of the community feeling. We put instructions on how to do this in the chat. Next slide. We encourage your questions and comments. Feel free to type questions in the chat and during the Q&A portion, using the black menu bar on the bottom of your screen to raise your hand, and the moderator will call on you. If dialing in to participate in the Q&A, use *6 to mute and unmute your line. We would love to have you come off camera or stay on camera and come off mute and ask questions, but again, feel free to just type them in the chat if you would like to. The Project ECHO model is designed to create a shared learning space for healthcare professionals through a series of educational sessions, fostering peer engagement and disseminating best practices in community care. This is session 2 of a 3-part series. Session 1 can be found on both the Blood Cancer United and NMDP's website by searching ECHO, and in the near future, session 3 will be held in January 28th at 5 p.m. Eastern, and that will also be posted after the recording. All interactive, all teach, all learn opportunities. The primary goal of the ECHO model is to effectively disseminate evidence-based strategies by leveraging a one-to-many approach, so each ECHO participant takes what they learn back to their teams and community. In the spirit of ECHO, we ask that you have fun, use this as a space to learn, and collaborate with one another. Be present be present and inevitably roll with the punches if and when technology issues arise. We will focus on patient cases which were introduced in session 1 and will be carried into today's session and then into session 3. We have polling questions and your responses are greatly appreciated. Now let's have our first polling question. What is your practice setting? Select all that apply. All right. So our largest portion is BMT, and then the HEMOC academic and HEMOC community. And then we have other practicing providers and industry. Fantastic. Thank you for answering that. Here are the faculty disclosures. I will turn this over to Dr. Holton.
Thank you, Darcy. So the first half will be focusing on an AML patient of mine. This is a real patient. The names, dates, ages have been changed to protect the innocent. And then after this case, we'll go to Dr. Lauren's case of ALL. So just to remind people who are here for the first session, or if you're new to this session, this is the background of my patient. This is a gentleman who had a right lacrimal gland marginal zone lymphoma in the 90s, had multiple treatments that would work for a time. He'd relapse. Ultimately, this transformed into a large cell lymphoma. In 2000, he received CHOP and then rituximab plus ibertumumab tiaxetin in 2009 and skin radiation therapy in 2009 as well. After several years of follow-up in 2015, he had no evidence of any active lymphoma. However, in June of 2022, he developed pancytopenia. A bone marrow biopsy at that time showed therapy-related AML, 56.6% blast. He had a complex karyotype and TP53 mutation. Felt to be a therapy-related AML, obviously high risk. He started azacitidine plus venetoclax therapy on our inpatient leukemia service. His course was quite complicated. He was in the hospital for a few months. He had mouth sores, weight loss, lightheadedness. But the most concerning thing that happened is he developed a life-threatening Aspergillus pneumonia, quite extensive, required a prolonged hospitalization and required no surgery, but just prolonged treatment with ambisome for this. Fortunately, he did respond to azacitidine and venetoclax, and he became a transplant candidate. Despite the Aspergillus pneumonia, he did respond to this as well, just required extended therapy. In discussing his case with our team, we ultimately decided that he would be a transplant candidate, and we plan to move him forward to a reduced intensity allotransplant. So that's kind of where we left off at the last session. So this session will talk a little bit more about how we actually proceeded with transplant for him. So keep in mind, this is back in 2022. This was before we had clinical trial results from BMT-CTN 1703 and many other studies. But this is what we did with the information we had at the time. He underwent a transplant with an 8 of 8 matched unrelated donor. We selected a 22-year-old male who was ABO identical, and we selected a peripheral blood stem cell graft. Conditioning, we went with a pretty light intensity regimen, fludarabine, cyclophosphamide, low-dose cyclophosphamide, and low-dose TBI, 200 centigray. His GVHD prophylaxis was post-transplant cyclophosphamide, tacrolimus, and mycophenolate. This was off clinical trial. This patient did not want to be on any clinical trials at all. He underwent his transplant, received the graft, received his PT-Cy, and then on day 18, just as he's starting to engraft, he developed confusion and profuse diarrhea. And so the question is at day 18, what is going on with him? He's just engrafting now. He's got some symptoms that are pretty unusual. This confusion is odd, doesn't make a lot of sense. Diarrhea didn't make a lot of sense either because he received pretty mild intensity conditioning. This is, not a super mucotoxic regimen. So we're wondering what is going on with him. Reference to just kind of keep in mind, we were starting to see some signals that maybe selecting a younger donor would be good for him. So I encourage folks to take a look at this reference, selecting younger donors that may be preferable over the best HLA match in the PT-Sci era. So we made this decision based upon the best available data that we have now, but we actually have new data that suggests that perhaps we made the right call. So next. So basically what he teaches us is that we can get people to transplant even when they have complications from their AML therapy. He certainly had a prolonged hospital course with his induction, but was eventually able to be outpatient and then move forward with transplant. Now, we're not going to go into all the details of his transplant course in this session. I'm leaving some of his symptoms as a teaser for the third session. So I want you to come back and join us in January to talk about what actually happens as we kind of resolve what is going on with him. But infection control is obviously essential, not necessarily disqualifying for transplant though. So even though he had bad aspergillus, we were able to move him forward. And we were able to treat him with this reduced intensity regimen and give him PT-Sci TAC MMF. It was manageable even in a complex patient who he was not a young person. He was in his 60s who had a lot of prior therapy. So I'm not going to reveal everything, but I wanted to open the floor for discussion. I don't think we have any slides after this, do we? Oh yeah, so want to open the floor for discussion, and this is a good intro to the polling question here. So for him, he's in his 60s, maybe early 70s. I don't recall his exact age in this scenario, but if you were seeing this patient, how would you proceed with donor selection? At your center, would you be looking for an HLA identical sibling donor? Would you be looking for a matched unrelated donor? Given the urgency for transplant, would you be looking at a haplo or a cord? So go ahead and submit your answers. And we'll take a moment and see what people said. So about a third of people said HLA identical sibling donor, but the majority is saying a matched unrelated donor. Dr. Mims, I'm wondering what your take is on these responses.
Sure. So, I think it's really interesting just because I think that sometimes donor selection is really center dependent on kind of comfort, what you're used to moving forward with and how quickly you can do that. I do agree that sometimes if you need to rapidly move forward, a haplo or someone related, if you have a full match available, might be the easiest. But I'm also curious, from your perspective, how you feel about, if there's really a right or wrong answer here.
What we could do is we could take down the screen and look at our community and see what others are thinking, if that's okay, Sam. What do you think? I'd love for anyone else to weigh in on this. Feel free if you're willing to come off mute and join us, or you can even type in the chat.
Chime in for a second. I will just say I found myself wanting to answer two things. Like we always look for siblings if they're the appropriate age and good health, but we also don't wait for that. And we're always sort of starting the donor search at the same time. The minute we know, we're thinking about the patient as a transplant candidate. And I think in general, an MDP is very rare, very responsive. And at least in our center, we have found that going for a sibling isn't always faster. I know that's sort of a common, perception that, unrelated donors take too long. But I think if you have the right search strategy and you start the search early enough, it's very common, at least in our experience, that unrelated donors are readily available. And sometimes those haplo donors, maybe they're not prioritizing it, or they have other things going on, or sometimes they have confidential health issues that they don't want to disclose that makes them not eligible to donate, but they don't want their loved one to know.
Right.
So I have found that unrelated donors, I'll always look for a matched sibling, but I'm never holding my breath. And I don't think that haplos are always faster. It's just my opinion.
I'm curious if anyone is willing to share their age cutoff for a matched sibling if you have one at your center. $55-ish, okay.
I feel like it depends. A 65-year-old sibling is better than no donor.
True.
And there are people who don't have donors still in this current era if they have a lot of antibodies or a rare HLA type. And so we have certainly used siblings that are pretty old, including one who was in her 70s, and it went okay. So, it's not our first choice, but
Yeah.
if it's transplant or no transplant, you sort of take what you get.
This is very true. I agree. I'll share what we're doing at our center, which is probably going to be controversial, but our donor age cutoff is 40 for a related donor. Obviously, if we don't have other options, we're willing to take a variance for that. But in our standard protocol, our age cutoff is 40. I'm too old. I've aged out.
Don't get me started. NMDP doesn't even want me.
I know. I've been on the registry for years and I've never been called.
Yeah, I would
Dr.
say,
Alsfeld? Yeah.
at our center, I think one thing that we look at, age is obviously an important factor. And I think in this person, your patient, to highlight the importance of reconstituting an immune system from some sort of donor, especially having recent fungal infection, a lot of other factors. To answer your question about donor cutoff, we usually try to look at under 60. But here in Louisiana, especially the variety of patients that we have, we do a lot of haplos. And so that does weigh into our factors here and age cutoff. But if we can find a fully matched donor, I'm usually willing to push that number a little bit. But I do think, of course, different parts of the country, that number, I would imagine, varies a good bit.
Yeah, Dr. Mims?
So I think it's probably similar to what Dr. Alsfeld mentioned, that we'll do up to probably age 60, but there are definitely certain circumstances where we'll go above, and just really dependent on the patient at hand.
Exactly. Dr. Wen in the chat had asked, is there significant data? So yes, there's data published from EBMT and more data coming from CIBMTR that's showing that donor age is pretty important. And so that's where we drew our cutoff from some of that literature. There may be exceptions, but just generally speaking, yeah, we are looking for the best donor, the fastest donor. But HLA, interestingly, today isn't always our first consideration. Sometimes it is other factors related to how quickly we're able to get the graft for some, and completely understand that, based upon family situation, what you've got for potential haplo donors, if you need to get to a transplant quickly and you've got someone right there willing and ready, it might be the best choice for a given patient. Ours happened to be of European descent. We had a ton of donors to choose from, but that is not always the case. Yeah, Dr. Lauren, do you want to take that question from Darcy?
Sure. So the question in the chat is about when is the best time to start a donor search. I'll refrain from, well, my family teases me that everyone should just have a search because you never know. But I think we typically know pretty early in a patient's course if they have a blood cancer that would benefit from an allo transplant. And I think there's very little downside to at least HLA typing the patient and starting a search. So we've implemented a system here where we have basically every new acute leukemia patient who's admitted automatically gets HLA typed with their admission labs, which, by the way, is really important because, of course, you need DNA, so you need white blood cells to type people. And so if you try to type them while they're natering, it's really hard to get enough cells to get an HLA type. So it's important to do it early. And you do not need to refer them to a transplant center. The NMDP has a terrific program called HLA Today, which enables HLA typing to be done even before the patient is seen at a transplant center. I know there's information about it on NMDP's website, and I don't know if Sam or anyone else on the call wants to just mention how that works.
Yeah, you can definitely go to our website. I'll put it in the chat, and you can fill out an interest form. And if you don't have access to HLA typing at your hemonc practice, we can provide it off the shelf via a simple buccal swab kit with prepaid FedEx envelopes, and we get it into the database of that transplant center anywhere across the nation that you need that patient to go to expand access. So I'll put the link in the chat. Thanks, Dr. Lauren.
And I
It's an
will
incredible
Thanks, Ann.
service. Yeah, it's just such an awesome service. Dr. Mims, there is a question from Lauren Berger in the chat about for a patient who has a fungal infection, such as aspergillus in this case, do you leave them on Ambisome? If the patient doesn't respond, what would you do? I'm curious how you would approach the fungal infection in this case.
Oh goodness, yeah. So I think we typically will do double coverage with Ambisome and like posaconazole, or voriconazole, depending on what the patient had been on for prophylaxis prior. But I do think that's a great question, is if they're not responding, what do you do? And I think we are more limited in those circumstances. Unfortunately, there's just not as many, treatment options, and I think would definitely impact the ability to move forward with transplant. And I don't know if others on the panel, feel the same. So.
Yeah, I would agree. I mean, I think obviously some control matters a lot before you completely wipe out what's left of the immune system. I think these scenarios are often challenging, and we've been, I'm sure you all can recall certain scenarios from your centers, but in our particular situation, a lot of times my thought is at least getting enough control to be able to get them through until engraftment. And hopefully that's then when you can see things really turn around, because if you imagine somebody that's been through multiple lines of treatment and their immune system is already close to ablated by that point, and then you're just kind of having to push through and hold your breath at times.
Agree. We were fortunate with this patient. He responded to his aza-ven. He had neutrophil recovery. He responded to his treatment. And I agree, we did double coverage through engraftment, and then it was just single agent. I don't recall if it was Vori or Posa, but he just had single agent therapy for several months then post-transplant. And we were fortunate, that aspect of his condition was able to be controlled. Agree that we typically would not be moving forward with a transplant if we were not able to control a fungal infection prior. This particular patient of mine was fortunate.
I will say to highlight, I see Anna's put some information there about HLA Today. One thing that I will share from our experience, Ochsner has facilities throughout the state of Louisiana and the Gulf South, and of course, this is a hotbed for disparities in getting to transplant and challenges in getting to transplant. And so we've actually really leveraged this HLA Today program. And so a lot of our community sites that we partner with, when I get a phone call about somebody with newly diagnosed leukemia, they're plugged in and able to send the HLA Today and send HLA typing before I can even get them into clinic or into the hospital to meet us. And so I think it's a really great program. It helps cut down on that time to identifying donors, again, before I've even met the patient. And I think it's a great program that I can't highlight enough.
That's awesome. Sam, do we have any other questions on this case or any other slides on this particular case?
We do have one more polling question. I can share the screen again and
Let's go for it.
we can go through.
Sounds good. Okay, which of the following test results is not considered applicable to MRD positivity to impact decision-making around the need for allotransplant? Single choice. Here we go. All right, Dr. Mims, walk us through.
Sure. So this is, I realize, a little bit tricky and wordy, but so I think where the correct answer, and I'll discuss it more, but is the detectable DNMT3A mutation, as that can just be clonal hematopoiesis. That wouldn't necessarily make a decision for or against transplant. What I meant through the positive NPM1 PCR testing after 2 cycles of intensive induction is that those are typically favorable risk patients, but if you're seeing that MRD positivity, you would think more highly of this patient actually probably does need a transplant, and intensive chemotherapy and consolidation is unlikely to be curative. The positive FLT3 ITD PCR testing, I think after completion of intensive induction consolidation, would be more around the discussion of, do you want to do gilteritinib post-transplant maintenance or not? I don't know that people would necessarily not move forward with a transplant in that setting. And then positive flow cytometry results at pre-transplant workup, I think, can be a bit concerning. There's still, significant disease, but it could depend on the type of transplant you're moving forward with and if there might be consideration for also post-transplant maintenance. And would love other people's thoughts around this, as a little controversial.
So it's so nuanced right now, right? It depends on the patient, what they have received, if the mutation is targetable, what their prep is, what their donor is. There's so much nuance. I don't know that it's all resolved. Dr. Alsfeld, how do you approach this?
Yeah, I think I can't agree more. I think the data is getting. I feel like we've opened Pandora's box, and we're getting more and more information, and it's created some blurred lines. I think one thing I always like to highlight, especially when you're looking at NPM1 PCR, to me, oftentimes if somebody's had, let's say, multiple lines of treatment, rather than pushing them and beating them up too much with the induction chemo or aza-ven or whatever route you're going, sometimes you can overcome at least the PCR with just myeloablative conditioning. And so you'd hate to miss a window to get somebody to transplant just because of NPM1 PCR. And so I think there are some nuances and certainly practice institution dependent. But I'm excited to see how it will all play out. But I think there's some scenarios where I usually will say, okay, well, there may be NPM1 still positive, but I'm going to push through transplant and just ramp up conditioning to overcome it.
Yeah, there's diminishing returns with more and more therapy, right, Dr. Lauren?
Yeah, I was just thinking that, there's an old expression in surgery that you shouldn't let the perfect be the enemy of the good. And sometimes, your window is your window. And I have certainly, I'm sure everyone on this call has seen, 2 more cycles of aza-ven, and then they blow through it, and now you've lost your opportunity to transplant. So I do think it's this is really because of, Clark, you said it really eloquently, this, sort of overload of information and not a lot of understanding about how to use it. I think this is where, unfortunately, we're still in the area of medicine where there's some art to this, and sort of having some clinical understanding of the biology of the disease, the biology of the patient, the donor options and how available they are. And sometimes you sort of have to proceed. I do like the idea of intensifying conditioning. I'm still a fan of myeloablative for eligible patients. I know that's a little bit maybe falling out of favor, but I don't think we have data to support that that's not helpful in the right patient. And so I do think that intensifying therapy in some of these patients when tolerable is appropriate.
I agree with you. I'm still on team myeloablative as well. We're fortunate that we have newer agents that are not as toxic. So triosulfan, right? We can deliver more intensity without so much organ toxicity. The thiotepa busulfan fludarabine regimen is excellent. So we have more choices for conditioning these days. We don't have to necessarily beat up organs to deliver more effective therapy. 10 years ago, I might have thought, well, if they're MRD positive, I really want to try to make that negative because I know that means that they're likely to do better with transplant. No, it's just a sign that their disease biology is different, and I no longer I'm going to try to go for that perfect because it does sometimes mean missing the window. And so moving forward with MRD positive patients is something that we do here. We just know that this is a high risk population, and then we will take that information and tip the scales in our favor wherever we can and hope for the best.
Yeah, and I'll just add to that I think this is really an opportunity for leukemia and transplant physicians to work closely together, because with the proliferation of testing and targeted agents, I think we're also in an era where we need to be thinking about early reassessment of disease activity after transplant, maybe not doing the usual day 100, maybe doing it at day 30 or day 60 bone marrow biopsy to see where you are, and then initiating some form of preventative or prophylactic targeted agent post-transplant if it's tolerated and if you can get it approved. That's a difficult setting sometimes to get the auth, but I think people are, again, you have to be cautious. There's not data to support this in many cases. I think a lot of us extrapolate from the BCR-ABL data and the FLT3 data that this can be a useful adjunct for even people with other mutations. I'm curious what you all think about that.
Completely agree. And I won't fully open the post-transplant HMA can of worms, but I'm just going to crack the can a little bit to say that studies are mixed, and there's a meta-analysis that shows an overall survival benefit. So how often do we see survival benefits in allotransplant with these manipulations? So, sometimes we go for a post-transplant HMA. Very controversial though still. So please come join us in January, where we reveal more about what happens with this patient of mine. I can't wait. But let's segue now over to our ALL case, Dr. Lauren.
Okay, great. Thank you. I think we have more slides. Great. So this was a patient that I introduced to the group at our last meeting. If you can go to the next slide. It's a 24-year-old transgender woman with Ph negative ALL, diagnosed when she presented with rectal bleeding and fatigue. And you can see the lab results here, pancytopenia. The diff was originally read as lymphocytes, and then a bone marrow biopsy was performed. Go to the next slide, which demonstrated, as I mentioned, Ph negative B-ALL with the profile on flows that you see here. I'm not going to read all those letters and numbers to all of you. No detectable mutations on NGS. There were 4 sequences observed on a clonoSEQ report and normal cytogenetics, and there was no CNS involvement at diagnosis. Next slide. And so this was a young patient with Ph negative disease. And so we covered at our last session the proliferation of ALL protocols that exist in the world. And I think one of the key learning points from that session was that all of these regimens are very complex and involve significant, very sophisticated understanding of the protocols to be delivered safely, with the key points being delivering full dose on-time therapy in a center that has experience with whichever protocol is selected. There's not a lot of head-to-head data comparing these regimens, but they all tend to have sort of a similar backbone and pediatric-inspired protocols, because these have demonstrated significant improvements in disease-free survival and avoidance of transplant in adults with ALL. And so, unfortunately, our patient still had 10% blasts after her initial course of therapy, completed course 2 and still had 6% blasts. And so at that point, even though there were no clear high-risk features at the time of diagnosis, the fact that there was persistent disease after completion of the first 2 cycles of treatment, as Dr. Holton had mentioned, indicated this is a high-risk patient. And so I met her actually during her first cycle of blinatumomab, and at that time, she ultimately achieved a morphologic remission. Her flow MRD was negative, but there were still a couple of clones present on her marrow. And so when I met her, it was sort of this murky, like she was eventually responding, but hadn't had an initial response. And so there was still some questions about her disease status and risk. And if you can go to the next slide. The dilemma that we faced was that after a second cycle of blinatumomab, she did attain an MRD negative remission by all of our available measures, including clonoSEQ. And so we were sort of stuck with this, well, okay, like we were sort of talking about this earlier, now has achieved an MRD negative state, but maybe now she doesn't need a transplant because she's now sort of gotten to where she needs to go, albeit through maybe some alternative pathways that wouldn't have been on the initial plan. She was very healthy, 24 years old, college graduate, had some mental health issues that were well controlled. And so really had no significant comorbidities that it would have put her at an additional risk for her transplant. But she had an unusual personal situation in that she was essentially estranged from her family and only had 6 out of 8 or less, fewer matched unrelated donors. She did have a number of cords, including the option for using an Amidubicel expanded cord. And then we also had to be thinking about conditioning regimen and whether, I think that as much as Dr. Holton and I are on team myeloablative, I think the evidence for myeloablative conditioning is weaker in ALL patients. And so thinking about how to avoid toxicity, particularly with higher risk donor graft sources, was something that we were thinking about. Maybe I'll stop and just ask my colleagues. This is like a lot to be thinking about. I'm just curious. Maybe Dr. Alsfeld, since you and I are paired up for this one, I'll start with you. What do you think about transplanting this patient?
Yeah, I think this area, especially, which is a good foreshadowing into my little piece of the puzzle about MRD, can be used and be very helpful in this kind of a scenario. So obviously, you have a less than ideal scenario for transplant with a really good response to treatment and MRD negative, and you have a lot of great treatment options that become available when you start thinking about blinatumomab and CAR T-cell therapy and inotuzumab and some really great available treatment options that in a lot of these patients, I think there are growing debates, in fact, really good ones at all of our conferences, it seems like, about should you even transplant a majority of these patients. And for a lot of these patients in CR1 and potentially even CR2, can you avoid transplant altogether and just start to utilize some of the other newer treatment options that are revolutionizing? And nowadays, especially with MRD testing, you can really identify those who are at higher likelihood of relapse and intervene sooner and prevent other complications. So if you had a slam dunk opportunity for transplant, you could make an argument for it, but even then you could use some of the other issues and say, well, maybe we just avoid it. Happy to hear what others think as well.
Don't take the slides down and see if anyone else on the call wants to weigh in. A little bit of an unanswerable question. So I see a question in the chat about whether NGS to detect high-risk mutations would help you to decide on transplant. So I think the answer to that is yes. In this particular case, the patient did not have any of these mutations. I do think that in the presence of those mutations, even if they ultimately achieved an MRD negative state, would be much more motivated to pursue transplant, knowing that there were these poor risk features present. But we really didn't have anything to follow for this particular patient. I'm curious what others think.
I agree. I mean, I think when you start to see a TP53, KMT2A, some other, that then pushes that cytogenetic risk up a little bit higher, or cytomolecular risk up a little bit higher. And for those, I certainly have at least spent more time in the discussion about transplant. I still think, there's some data that especially TP53 mutations and persistence of such can increase the risk for relapse. And so I think the conversation around transplant then becomes a little bit heavier, but I think also you have to take into account your patient, your donor options, and whether or not you may increase the risk of complications with those things weighing in the newer area of cytomolecular, how that influences transplant decisions.
Yeah. Dr. Holton or Dr. Mims, anything else you want to add?
Yeah, I think what was stated already was really nice, and so I don't have anything additional to add from my end.
I'm going to make it more complicated. So if I were managing this patient, she's got only a clinical high risk feature in that it took her a long time to achieve CR, but she's in CR now. Social situation isn't great. Donors aren't great. We've got 2 strikes against transplant. And then you've got a really good method to monitor her. And then if she does relapse, you have CAR T, which hasn't been mentioned yet. So here's the question. If we just, continue with consolidation, maintenance, and she relapses and you move forward, then eventually in the relapse setting with CAR T, does she need a transplant after her CAR T?
So it's so funny, so to reveal to the rest of the group, we were talking before we all got on the call about what other questions would pertain to this patient. And actually, Dr. Holton, that is exactly what I was thinking about. And it's a question that I think we all really struggle with. Of course, we know that there are very long-term remissions, dare we call them cures, after CAR T alone. Our practice typically has been to still proceed with allotransplant, but I know other centers don't, including CHOP across the street from us. So it's tough. What would you do?
Yeah, I think to weigh in on that, I mean, you're still stuck with the challenges around transplant in this patient. You take the social factors and the other factors out of the equation. I think certainly transplant could be considered, but I still think there's a very strong argument if you have good MRD monitoring, serum monitoring of MRD, at that point, re-challenging with something like Blina and then go to transplant or trying some other method post-CAR T. I think in this kind of a patient, that's maybe the route that I would consider, and hoping maybe the social factors can get better over time and rekindle relationships. And I think you can find ways to transplant in the future if need be.
Yeah. Can you put the slides back up?
The piece that I just sort of, the piece that
Yeah.
I kind of cringe about, that I worry about is if this patient, relapses again after CAR T, what do we have? Is it inotuzumab time? And then there's risks there.
Right.
It's really tough.
It's sort of like, you sort of have it on the run, and so do you just consolidate your advantage or take a risk? I know it's so difficult. I think that's where, as my mentor would have said to me, really good informed consent, which I think is, I think it's of course important for the patient to express their preferences and weigh in. But this is the place where I struggle. Like, we are experts and we don't know the answer. And so asking a patient, I mean, of course, we want their input and they need to participate in the choice, but it's a lot to ask of a patient to sort of really make a decision when we even don't know the answer. I probably should have put this up sooner. For people who had joined us last time, they were aware of the additional psychosocial issues. And of course, the team here knew about it. So I apologize for sort of jumped the gun a little bit. But in addition to being alienated from her family, there were other psychosocial challenges as well. She's very well educated, super smart. Actually, one of the conversations we had about Amadubicel, she was really interested in that manipulation. And so I actually gave her the literature to read because she was interested. But she didn't have a great socioeconomic situation. She was working in food services and had applied for disability, but really didn't have any dedicated caregiver support. She had friends who were mostly roommates. Pennsylvania has a state program to pay for caregivers, but the state denied her. And it's actually been interesting in Pennsylvania, until they get the transplant, they're considered too well to qualify. So you actually have to apply like after they're sick, which then you're like, well, hopefully they get it. And if they don't, you've already transplanted them. So that's been challenging. She lives quite far away. Again, we're fortunate in the Philadelphia region. We have several wonderful philanthropic organizations that will allow for local housing, but they all require a caregiver to stay with the patient. They can't just stay there by themselves. And I will add that both NMDP and Blood Cancer United provided support for this patient, although since she didn't end up going to transplant, I think ultimately that was just the Blood Cancer United team that ended up supporting her. But I think we may have gotten some funding from NMDP as well. So I apologize if I misspoke that. Okay, and then next slide. Okay, so we talked a little bit about this. I think there's sufficient evidence to suggest that a 7 out of 8 mismatched donor in the era of post-transplant cyclophosphamide offers comparable outcomes to matched unrelated donors, to Dr. Holton's point earlier. We talked about the fact that she had several really good cords, but again, a very difficult psychosocial situation. And I think this may be, oh yeah, so then the other thing we thought about was, well, our team talked about her before the second cycle of Blina, before we knew she ultimately was going to become MRD negative. And so we talked a little bit about the possibility of offering CAR T now before the second cycle of Blina, because the thought was that CAR T would be less toxic and less risky than allotransplant. So our plan was, after the second cycle of blinatumomab, if she still had detectable disease, we would have gone to CAR T now rather than allo, with the idea that the conditioning was less intensive, the toxicity is less toxic, and sort of getting at our previous discussion, possibly curative. But of course, as everybody is aware, you need to have active disease in order to expect CAR T to be approved. And so, and similarly, we have some clinical trials here of CAR T, but that was another consideration. But again, had to be still had to have disease in order to be eligible. So we sort of covered this already, but we really struggled with what to do. Ultimately, of course, did engage the patient in the conversation. And given the risks associated with cord blood transplant, the lack of a consistent caregiver, and the fact that she actually ultimately did achieve an MRD negative remission, we actually decided to defer transplant. And so she's gone back to her leukemia team for continued maintenance therapy. And she's doing fine. So our polling question, all of the following should be taken into consideration when evaluating a patient for allogeneic stem cell transplant, except, so which of these should you not consider when you're thinking about transplant? All right, how did we do? Yay, you all know. So yeah, I mean, I think that obviously insurance is a huge issue for our patients and sometimes is a marker of, you know, social determinants of health. But I think that we're fortunate that in general, insurance typically does cover transplant with few exceptions. And so it really ideally shouldn't be a consideration when you're thinking about who should be transplanted. Okay, so I'll hand it over to Dr. Alsfeld now.
All right. Well, I think this is a great segue. We'll start with a polling question, or which of the following are available or approved in the U.S. For measurable residual disease testing or MRD testing in ALL? Okay. So I think that's great. You know, the reason we wanted to focus a little bit about MRD is because, as you all know, this is really, as our conversations have indicated here, revolutionizing the way that we look at treatment of ALL and how we can prognosticate in this disease. So if you can go to the next slide, please. Thanks. So starting by really just answering the question, all are currently available. There are other ways to assess MRD that are available in other countries. I really just wanted to focus on primarily what was mainstream here in the US. The first and foremost is multi-parameter flow cytometry. As you know, you're assessing for leukemia-specific immunophenotypes with very good sensitivity. You're looking at 1 in about 10,000 cells that can be identified on MRD testing. It's great because it's fast, it's inexpensive. You don't need a pre-treatment specimen. So it can be used pretty readily, and it's probably something that a lot of people are very familiar with. The disadvantage is, compared to some of the newer options that we have available, the sensitivity is less comparable to some of the other options. The other thing to take into account is you can have false negatives if there's phenotypic, or if there are phenotypic shifts that happen within the leukemia. And then, of course, there can be some interlaboratory variability between institutions.
Okay.
Looking at
for a walk today?
looking at another option is using RT-PCR. As you know, that's leukemia-specific fusion mRNA, in this case BCR-ABL, a little bit more sensitive. So you're looking at 1 in 10,000 or 1 in times 10 to the minus fifth, even in some scenarios. It is simple to perform, and it uses standard primers, so you can use it reliably across institutions. The downside is, though, it's really only available for fairly positive ALL. And then one thing to consider here are the opportunity, the chance for false positives. So, of course, if there is multi-lineage BCR-ABL included, you can have some false positives with assessment of that. It doesn't allow for specific antigen expression. But the third option, and I think the newer and probably most exciting that we've referenced here, is using NGS for the immunoglobulin T-cell gene rearrangement, commercially available, known as clonoSEQ. clonoSEQ is a really interesting technology where they use unique sequences within the immunoglobulin genes or the T-cell gene rearrangement to identify kind of a unique profile of the leukemia that's then stored, and then you can use NGS to then redetect or not those sequences in subsequent testing. So based off that technology, it really has our best sensitivity, 1 times 10 to the minus 6, and it really is very specific for leukemic sequences. The disadvantage, though, unfortunately, is cost. As you can imagine, this is very labor intensive, and so cost is certainly a factor for a lot of institutions, which may limit some centers from doing this. The other thing to consider is the need for a pre-treatment specimen. So if they show up on your doorstep and already have had treatment, it's often challenging or impossible to get this unless you have a pre-treatment specimen available. So I think these are really just to give you an overview of what MRD tests are available, so you can kind of understand what we're talking about when we reference these. Sample source, though, is always an interesting question, because I think all of us can probably universally agree on one thing in this, is that peripheral blood testing would be ideal. But you have to take into account the fact that peripheral blood testing, while easier and maybe preferred by patients and providers, what we're doing this for is sensitivity. Our goal of all of this is sensitivity. So you obviously want to find the most sensitive test that you can get. It is known that with RT-PCR, there can be a 1 to 2 log-fold decrease peripherally versus bone marrow. We still do it, and I won't say that I'm somebody that will do it frequently, but I take that into consideration when monitoring patients. When we look at NGS MRD, so clonoSEQ, that becomes a little less clear. I think the sensitivity may be comparable. It may be a little bit less, but really take into account a lot of times when you're assessing for MRD long-term, if there's low disease burden, your sensitivity may fall off in peripheral blood testing. So something that I usually think of if we're going to do clonoSEQ, confirm that they're MRD negative in the bone marrow, and then monitor peripherally if the pre-test probability for positivity is low. I think that's an approach that a lot of us have taken, so you can kind of match a patient preference and what's easier with what gives us the most comfort in knowing that they're truly MRD negative. The last and probably less clear answer is timing. Timing is a question that I think we can all have different opinions here. The very quick one-liner is it's going to be institution dependent. I do think that, of course, with clonoSEQ, having a baseline becomes very important. For the other measures, not so much. There's certainly plenty of data that end of induction MRD positivity is a poor marker. So I think in that setting, you can certainly argue end of induction assessment is very, very important and can help shape your decisions going forward for treatment. There's a wonderful meta-analysis that really kind of sparked all this in 2017 that showed that the likelihood or the disease-free survival was significantly less in patients who were MRD negative after treatment at the end of induction versus those who were MRD positive. So end of induction, I think, is one we probably can all agree upon. And then, of course, end of consolidation if you're not gearing towards transplant. The next step is whether, if they are going to transplant. So pre or post-transplant assessment, there are data that certainly if somebody is post-transplant MRD positive, there is a higher likelihood of relapse in that patient population. And so it can be helpful for informing decisions of maintenance or what other strategies to consider. But then what to do from there, the follow-up surveillance, that's where it really gets blurred. And I think we can all probably weigh in on what each institution does. Generally thinking they're 3 to 6 month window for maybe the first 2 to 3 years or something like that seems like a good ballpark, but curious to open it up to others and see what others think.
At our center, we give them back to the leukemia team so we don't have to think about it. It's not very fair though, is it?
That would be a great topic, I think, though, because we struggle with this too. Like they're seeing the transplant team so frequently, it's sort of easier to send it, but then it's months later and they're relapsing, and now the leukemia team has sort of moved on. I don't know. I think it's really hard to figure that out. We have struggled with that coordination of care. But I agree. I also think I'm also thinking from like a sort of healthcare utilization perspective. I think at our center, maybe this reflects anxiety of living in Philadelphia. We send everything all the time. And it probably makes more sense to just send what's positive, right? Like, why are we sending no negative tests? And it may just be a reflex thing. I don't know. People are just busy and they're ordering. But, I think having a really organized approach to knowing what to send and when to send it can be really helpful just from like a practice standpoint.
Yeah, I definitely agree with that. I think that's something we're working on currently at our center for an SOP to help direct, especially as different providers or, APPs may be ordering and things, and just so there's better direction to think about what you should be ordering for individual patients. It's very nuanced.
All right. Well, I think then I have one more polling question just to kind of piggyback off of these discussions of what do you use at your institution? I think it's a good segue to see what everybody does. Kind of what I expected, a little bit of everything. And I think this is really where hopefully in the future we can get more information with a lot of the great research that is being poured into this area. Hopefully we can get some answers to all of that and get some clearer guidance.
So I am going to move on to some complications of therapy, CAR T-cell therapy, and allogeneic stem cell transplantation. And I'm going to cover the early complications and the complications that come right up front with treatment, because in the next episode, if you stay tuned for the next session, we'll talk about later complications. So treatment-related complications in AML, of course, we have the myelosuppression with whatever treatment induction chemotherapy we're giving, with the neutropenia, anemia, thrombocytopenia. And of course, we can see infection, bleeding, fatigue, and then we would do transfusions, prophylaxis, and GCSF. And then, of course, as we've already heard, fungal infections, viral, bacterial infections. And obviously, antimicrobial prophylaxis and early antibiotic treatment plays a big role in this complication. We can see tumor lysis syndrome, allopurinol, rasparicase, hydration is really important as well. And then cardiotoxicity with the anthracyclines, making sure we get that echo prior to initiation of chemotherapy, if we can do so. It's really important. Neurotoxicity with that high dose cytarabine is really important, that we're doing those neuro checks and then dose adjusting and or curtailing treatment altogether if we run into significant complications like ataxia and then mucositis, and the list goes on, but I had to cut it off somewhere. As many people know, there's a lot of complications that can come with AML, and people can have them all or none at all. And then we will move on to treatment related complications in the B-cell ALL population. And again, we're seeing a lot of the same side effect issues and complications, myelosuppression, the infections, really making sure with the long-term steroid use, because we can see complications from steroid toxicity, the hyperglycemia, but as well as in infections, is making sure that you're doing prophylaxis for pneumocystis pneumoniae because of the long-term use of the steroids. We can see the hepatotoxicity just from the different types of treatment that they're on, a lot of elevated LFTs, and making sure we're monitoring those and then making dose adjustments that are appropriate. And of course, we can see pancreatitis and thrombosis, especially with aspergillus, but also we can see pancreatitis as a blinatumomab side effect. So making sure that, you know, those workups are being done if a patient presents with abdominal pain. And then we can see, of course, the clinical indications of DVT, CNS thrombosis. So making sure we do just, discontinue whatever medication we need to, supportive care as we move through that one. Neurotoxicity, again, we can see that with vincristine, methotrexate. We can see neuropathy, and then encephalopathy, seizures. And again, that's a dose adjustment, supportive care, and potential discontinuation of a treatment if we see significant complication. And as I mentioned, steroid toxicity, we need to be very mindful with steroids and the long-term steroids that those that are diabetic, we need to get them into endocrinology, but then that we can create diabetes and steroid-induced diabetes for patients and making sure we don't miss that for patients. And, we can see where they'll end up in the ER with blood sugars of 600 and they've never been, diabetic previously and have no family history. So just making sure that you're conscientious of that with the steroids. And then, of course, we can see osteonecrosis and that they might need some bisphosphatates and then rehab to help with that. And then moving into the CAR T-cell therapy complications, the two upfront ones that we can see usually, and they can be simultaneously, is the cytokine release syndrome, CRS, with fevers, hypotension, hypoxia, and that can usually happen within the first 14 days. We can see it happen longer, later than that, but it's usually in the early portion of CAR T. And this is an inflammatory response and elevated cytokines such as the IL-6. And, we use tocilizumab as well as corticosteroids. And, there are some indications that people are trying to use toci and steroids sooner to decrease the risk of grade 3 or higher CRS, which we can see in about 50 to 75% of patients, and that varies based on the product. So, but we still have a concern that this can decrease the long-term efficacy of CAR T. So we have to be very mindful of using those too soon. And then with ICANS, the immune effector cells associated neurotoxicity, again, aphasia, seizures, encephalopathy. And like I said, this can overlap or it can even follow CRS. So it's really important that we do a really, really good assessment and kind of understand which one we're dealing with, or are we dealing with both of them. We can see it with elevated cytokines and it's an endothelial activation. So again, corticosteroids, dexamethasone, seizure prophylaxis, and ICU monitoring. Then we can see the hypogammaglobulinemia with the low IgG levels, recurrent infections. This can persist for months and years. I've seen patients for years have very low IgG levels, and it's a B-cell aplasia. And of course, IVIG replacement is the management for this. And then infections, bacterial infections, fungal infections, which in B-cell ALL we see rarely. It's about 1 to 6%, I think, is what I read from fungal infections post-CAR T. So it's not real common in the B-ALL patients. But of course, we can see it early and then late, and then immunosuppression and lymphodepletion and then also management, antimicrobial prophylaxis, vaccinations. And we can see prolonged cytopenias, but I wasn't going to touch on this because that, it can be a very long-term complication that we see. So in the early allogeneic transplant complications, early complications. I tried to keep this under the 90 days and even under 30, but as you can see, like viral reactivation, we can see all the way up to 180. So I tried to keep them because there are the mid and the late complications, but we can see infections, bacterial, fungal, viral. Because of the neutropenia, it's really important, the mucosal barrier injury, making sure we're watching for that. And again, antimicrobial prophylaxis. Graft failure or delayed engraftment. This is again a very small percentage of patients that this occurs, but it can occur in 2 to 4% or 2 to 4 weeks, excuse me, with persistent cytopenias and poor chimerisms. We treat that with DLI, growth factors, obviously doing an evaluation for rejection. And then the acute graft versus host disease. This we see in the first 20 to 100 days. And this is where the immune cells of the donor attack the recipient cells. And we see that it used to be about 40% of patients had graft versus host disease. Now we're getting it down to about 28%. But there's a lot of good factors as to why that's getting better. We get rash, diarrhea, liver dysfunction, organ dysfunctions, and we treat with corticosteroids, tacrolimus, cyclosporin, and rituximab. And then, like I mentioned, the viral reactivation. And I think the next slide, I think that's it. All right. With that being said, we will move into our closing NMDP and Blood Cancer United resource slides. And I am pleased to share free resources with you for you and your patients. And for the healthcare professionals, Blood Cancer United offers in-person rounds and symposia, as well as CME and CE online webinars. We present the webinars live and then record and post on our website. We also offer a podcast channel where you can listen to healthcare professionals discuss treating blood cancer, side effects management, and more. New and interesting topics are added every few weeks, and you can access these videos and fact sheets for healthcare professionals at bloodcancerunited.org/CE. Next slide. For free resources for patients and caregivers, Blood Cancer United info specialists are highly trained oncology social workers and nurses who provide accurate and up-to-date disease, treatment, and support info, including financial assistance. Patients can contact them directly, or you can complete a referral form. We encourage you to refer your patients within the first 90 days of their diagnosis. All services are available by phone, live chat, email, or through referral forms. Contact info is on the screen and in the slide link. Next slide. NMDP's mission is to save lives through cell therapy with a goal of creating a world where every patient can receive their life-saving cell therapy. They have facilitated more than 130,000 transplants since 1987. They have a portfolio of free resources for patients and providers, including financial grant opportunities, bilingual, and psychosocial support. Next slide. NMDP offers the HLA Today program, which we've already talked extensively about, but the program does offer free fast typing to facilitate an early donor search so that at the time of first consult, the transplant center already knows the patient's donor's option. The swab kits are provided to patients and family members, and the NMDP delivers the initial search report to the transplant center of your choosing. This is all free of cost and insurance paperwork. And then the information was in the chat, so please refer back to that. Next slide. We hear time and time again from our hematology, oncology, and transplant partners that clear pathways of communication and good coordination are essential for getting patients from the hem-onc practice to the transplant center smoothly. Building these bi-directional pathways requires an upfront investment of time and resources. NMDP can help you build those partnerships and processes so you can have an effective and trusting relationship with your transplant center. Thank you to our amazing faculty and to all of you for sticking with us and enjoying this fantastic conversation. We hope you join us on January 28th at 5 p.m. Eastern for session 3 titled Coordinated Care for Transplant to Survivorship. Thank you again and have a wonderful evening.